Right. Hello, everyone, and welcome to our shoulder pain webinar. My name is Josephine Trotter. I'm the head of marketing at the Horder Centre, and I'm delighted to be joined this evening by Mr. Matthew Ricks, a consultant orthopaedic surgeon who specialises in shoulder, elbow and hand. Also a consultant at East Sussex Healthcare NHS Trust, Mr. Ricks is actively involved in teaching, research and professional societies, including the European Shoulder and Elbow Society and the British Hand Society. We've got a really interesting session this evening where we'll be exploring how to manage shoulder pain effectively and the different treatment options that are available, including rotator cuff surgery and shoulder replacements. Before I hand over to Mr. Ricks, I just want to remind you that this session is being recorded and the video will be emailed to you tomorrow. Also, we're unable to respond to raised hands, so please, if you do have any questions, can you type them in the Q&A section on the side and we'll answer them at the end of the session. Thanks again for joining us, and please welcome Mr. Matthew Ricks.
Thank you, and good evening. Thank you for joining me tonight. So I've been asked to cover two main areas, so shoulder replacement and cuff tear pathology as well. So we're going to cover quite a few aspects of this in our time, and then I believe there's a couple of questions to answer at the end, and hopefully we can clarify some points with you. I'll take you through some of the journeys that my patients have done with both of these pathologies and troubles. So we're going to cover some shoulder problems. We're going to cover how these patients present and the problems that they have and what symptoms they tend to report when they come and see me in clinic. We're going to look at shoulder replacement, the different types of shoulder replacements, and then we're going to look at the recovery and rehab following the surgery that we perform. I'm going to try and go through what you would expect from your shoulder replacement and the outcomes you'll be looking at and what sports activities you can hopefully return to after a shoulder replacement. Shoulder replacements are a commonly performed procedure done throughout the UK, and we are a very high volume unit down here on the south coast of England because of the demographics of the patients that we have. I'm then going to move on to have a look at cuff tears. And I'll go through a little bit of anatomy, not much, and this will go through why cuff tears can be a problem, what they present with, the treatment options available. Then I'll go through the recovery and rehab that my patients have following any surgery for this, and what you can expect from a cuff repair as well. Now, both of these topics tend to be quite linked, which is quite nice, and so hopefully they'll overlap at certain points as well. So the first up is who am I? So I'm Mr. Ricks. I'm a full-time NHS consultant over at Eastbourne and Conquest Hospital, and I work privately at the Horder in Crowborough and the Montefiore over in Hove as well. I'm a high-volume upper limb surgeon, and I'm a high-volume arthroplasty surgeon as well. I'm one of the highest volume shoulder replacement surgeons in the country. So I do a lot of shoulder replacements for both elective and for trauma shoulders as well. It's a particular interest of mine, as well as keyhole surgery of the shoulder. My experience is, so I'm from Sussex originally, so I was a consultant up in the north of England, a tertiary unit for a number of years, doing complex upper limb surgery, and then the opportunity came to come back down south, and now I'm back where I'm from in Sussex, hopefully treating the patients of Sussex. So there are a couple of areas I've got an interest in. One of those, as I said, is arthroplasty, and one is the application of modern technologies to arthroplasty. So I'm going to go through a couple of aspects from our 3D templating to the potential robot that's coming with shoulder arthroplasty as well. A couple of interesting areas for shoulder arthroplasty that's coming over the next few years. So a lot of my patients present with shoulder pain being one of the main symptoms that they report. This is a pain commonly over the shoulder area. It can radiate up towards the neck and radiate down the arm as well. So it's not just an isolated shoulder pain. It can be radiating up to those two areas. Commonly, it's a pain that all the time, particularly worse after activities. And a lot of my patients report worse at night. The reason it's worse at night is that your muscles tend to be quite inflamed from your day activities, but also the sensory noise of life disappears at night. And so at that point, you realize that your shoulder's probably been aching quite a while, but you become more apparent and aware of it at night when you're lying in bed. The other thing that patients report is their decreased range of movement they get. In turn with that is the functional impairment that this decreased range of movement and pain give them. Because if you're unable to move the shoulder and you're unable to hold objects and manipulate and do activities, then it greatly impacts upon your day-to-day life. And what I find a lot of the time is a lot of my patients have these problems for a number of years. And so what they actually find is for the first few months to years, these symptoms impact upon their day-to-day activities, they're aware of them, but then they start stopping activities. That's another factor I ask my patients. What activities does this pain, does this decreased function impact upon you and stop you doing, and what you used to be able to do before, and how much it impacts upon their life? Because we find a lot of the times when you have quite severe pathology or trouble with your shoulder, this can cause quite a limit on the quality of life that you can have. So with hips and knees arthritis, you're limited to walking and it becomes very apparent. But with shoulder arthritis, the limitations you have are just as great, but you're not as aware of them because most of the time people stop using their shoulder, stop doing activities, aware that certain movements of their shoulder will impact upon their day-to-day life. And one of the big triggering factors is decreased function, but pain. And it's the night pain is one of the main triggering factors that patients report is why they're going down the shoulder replacement route. So one of the two main causes to go down the shoulder replacement route is shoulder arthritis and cuff tear arthropathy as well. So I'll go through those two aspects and discuss in a bit more detail. The shoulder arthritis, similar to other parts of the body that can get arthritis, like your hips or your knees, is slightly more common. You get a narrowing of the joint space, and this means the joint is grinding away. And when the cartilage goes, this means that the forces going through can cause extra bone to form. So this extra bone around the joint can lead to the decreased range of movement that you're getting. So your nice circle or sphere of your humeral head no longer remains a sphere and becomes flatter with extra bone around the edge. So that's why if you have severe arthritis, you may have a limitation of your movement to such a degree that you can't go any further. And that's not because of tightness of tissue. That may be due to extra bone, collapse of an area of the head, and the advanced arthritis that can lead to that limitation. So no amount of pushing, stretching, or activities may get you beyond that bony limit that you have. So a lot of these patients with the advanced arthritis will have the pain, the deep set ache in the shoulder with the radiation as well, the decreased range of movement. Sometimes there's a history of trauma, particularly some histories of dislocation. So I have a lot of patients who used to do a lot of activities when they were younger, histories of dislocations, and then they present with arthritis at a later age. And because of this instability, because of the movement and the dislocations they've had over the years, this can lead to damage of the joint surface and in turn lead to them having advanced arthritis at an earlier age. The commonest age or the average age of a shoulder replacement is between 60 to 65. I do shoulder replacements in younger patients. The majority of my demographics down the south coast of England tend to be a slightly older population, and then they tend to have developed arthritis over time. A lot of them have had other joints replaced and come looking to discuss the options of a shoulder replacement. The other main cause of shoulder replacements is something called cuff arthropathy. So to maintain a moving shoulder, you need the ball to remain within the socket. So this requires functional muscles around the shoulder. So what we found with some patients is that you can accumulate over life tears and injuries to your cuff, whether this is occupation, activities, or hobbies, which in turn leads to the tears of the cuff getting bigger, and with time propagating to such a degree that the ball can no longer be held in the socket. And the problem with that is that the ball, every time it's pulled by the big muscle on the outside of the shoulder, is it moves up. And so when it moves up, this means the patients lose their function. So this condition is called cuff arthropathy. So the big factor with this is because the damaged cuff, the ball can no longer stay in the socket, and the ball is actually pulled north. And the problem with this is that there's no soft tissue procedure, no wondrous invention that can bring it back down. The ship has sailed, horse has bolted, and the problem we've got is there's no way to maintain that ball in the socket. So this patient group tend to have a significant decreased movement in their shoulder, a clunking, a pain in their shoulder, and sometimes there's a history of multiple traumas over the years where they may have torn their cuff and in turn ultimately led to the cuff failing and the ball no longer staying in the socket. So these patients have a history of trauma, sometimes they don't, because a lot of patients will have an element of cuff tear with the degenerative changes that occurred with life. Some patients have had previous surgery before from cuff repairs, but the key aspect of this pathology is that the head is no longer in the socket, the shoulder doesn't move normally, and when the muscles pull it, it goes north, which means you get this horribly decreased range of movement that my patients report. With this poor range of movement comes the pain and, more importantly, the loss of function. So you're unable to lift items up, you tire and you fatigue very easily. And I find that my patients find that it impacts upon their life quite significantly. They find the shoulder is useless. They end up using the other arm a lot more, and they end up stopping doing activities or getting help from people because the activity they know they can't do, or they have a significant pain with it. So with this cup arthropathy, as I mentioned, the cup or the muscles around the ball and socket no longer hold it in, and it shifts north. So the pull of the muscles leads to it going up. So this leads to the poor movement. This leads to the functional impairment that my patients report. And the loss of movement that the patients really complain about is their ability to lift the arm up. Now, if they are able to lift them up, it's not usually above shoulder height. It's usually in an arc well below that. They also fatigue, they tire easily, and they complain of pain. They're unable to lift heavy objects. They tire very easily, and they find that any repetitive activity leaves them exhausted or they're unable to do. A lot of patients find, particularly arthritic ones where they have that extra bone, is rotation of the arm is greatly limited as well. They find that sometimes they can only rotate the arm out to the midpoint or a central or neutral position, and they can't go beyond that. So that may be a combination of cuff tears. That may be a combination of that extra bone I mentioned causing bony blocks. If you do not have a smooth ball, then when it rotates round, the extra bone can impinge and catch within the socket, causing your problems. The patients report that the rotation's an issue. Some patients find it very difficult to get their arm around the back. A lot of patients who used to be able to go round their mid portion of their back can't even go anywhere near that at the moment. They find it significantly painful, and that every rotation can leave an ache after it. And they find that sometimes that block really does impact upon their activities. So if you're suffering with the shoulder pain, the pathway that you go down would be to be referred in to come see us, and then we'll start by examining you, taking a full history, picking up those impacts upon your life, functional impairment you're getting, and your medical problems as well. So this allows us to build up a picture about you so we can see where you are on your journey of your shoulder pain that you're having. We'll then do some appropriate investigations, which commonly are in the form of an X-ray. This is done on site. And then an MRI in some particulars, and a CT scan if we're starting to plan surgery. These are all investigations that we can do on site. So just because you've got shoulder pain, you're coming to see me, doesn't mean that you're going down the shoulder route. A lot of my shoulder pain patients, or even my arthritic patients, are a spectrum. Some are at the point where they've got such severe pain they can't sleep at night without severe painkillers, where they're constantly up waking every time they roll on it, and they have a very poor function, and the arm is completely non-usable. This is one end of the spectrum. You have the other end of the spectrum where they have mild to moderate arthritis. So these are the patients who are still functioning, the ones who are still working, the ones who may get an ache, but it settles with painkillers. So the spectrum of your shoulder pain and your shoulder arthritis or cuff arthropathy will be seen, examined, and investigated by us. Now, the milder forms we can potentially treat with injection and physiotherapy. So just because you come and see a shoulder surgeon doesn't mean that you're going to have surgery. We will tailor your treatment depending upon the pathology you have and where you are in your journey of your shoulder pain. So the injections in particular, when it comes to shoulder arthritis, are into the shoulder joint. So these injections commonly performed under image guidance, whether this is ultrasound or X-ray guided. We pass the needle into the shoulder joint with a local anesthetic and steroid in a clean way, try and decrease the risk of infection. The main risk of an injection would be infection and reoccurrence of your symptoms in your lifetime, because obviously this may not be the cure for the marching arthritis that you have, but ultimately may settle it for a period of time with an average of about 6 months improvement in mild forms of arthritis. This is a way of trying to bring down the inflammation and swelling of your joint. Because with arthritis, it's a fluctuating course. Yes, you may get that extra bone, you may get that loss of cartilage, but you're going to have points where you'll do activities where it becomes more inflamed, more swollen and sore. And so injections can be helpful for those type of patients who are at that time during their journey of their shoulder pain. Physiotherapy is key at most points of your shoulder treatment plan, because it's important that you maintain the shoulder muscles around the shoulder. It is important that you do the exercises and activities that isolate the muscles around your shoulder and tendons to beef them up so you get the maximal movement of what you can. If I have a patient who's already undergoing physiotherapy and doing exercises and activities, I encourage them to continue doing the exercises to maximize the muscle bulk that they have. And then ultimately we will see how their journey goes with the injection of physiotherapy. Because as the arthritis progresses, or if you come to me further down the line and you've lost that movement, or you've tried physiotherapy and injection and you're still significantly impaired, then we discuss surgery. The surgery is never the first port of call, it's usually the last resort. And so we'd explore the other areas first before we go down the surgery route. Now, when it comes to joint replacement, there's been an evolution of joint replacement over the years. And there's been some areas that have specialized in it. There's been some joint replacements that have come out from certain areas. So I think the main types you need to be aware of are your anatomical, your reverse, and your hemiarthroplasty shoulder replacement. Now, a hemi means half, so it's half a shoulder replacement. This isn't commonly done nowadays, and I'd say the majority of my practice is made up with either a reverse shoulder replacement or an anatomical shoulder replacement. So if you come in and see me in clinic and we've discussed other options, you've had the treatment already for injection and physio, you've got that limitation of movement, you've got that constant pain and it's impacting upon your life, and we've exhausted conservative measures, then we'll have the discussion about the shoulder replacement. Now, the shoulder replacement main type, as I said, is a reverse and an anatomical. Now, the key factor with this is you need a functioning cuff. So from an anatomical point of view, this sounds like it should be the most commonly performed. It's not. So I find the majority of my patients will have cuff tears, cuff pathologies. That means I can't do an anatomical shoulder replacement. So I'd say that 90% of my shoulder replacement practice is made up from reverse shoulder replacement. So first up, go through the anatomical. The anatomical patients tend to be the ones that have functional cuffs. So this is the muscles around the socket are fully functional. So coming back to that cuff arthropathy, we wouldn't do this type of operation in that patient because that pathology is indicative or indicates that you don't have a functioning cuff. So therefore, a reverse shoulder would be for that population of patients. If you do have a functional cuff and you have established arthritis and you have good quality cuff, then we could consider doing an anatomical shoulder replacement. So this is, we call it anatomical because we're trying to maintain the normal anatomy of the shoulder. Your ball remains a ball and your socket remains a socket. So the bearing surface, this is what a lot of my patients ask to see whether it's anything experimental or anything weird and wonderful, or whether it's metal and metal. It's not. It's the tried and tested metal on plastic liner. So this is based upon the Charney hip replacement invented up at Wrightington, and this is the commonly done bearing surface that provides the longevity of the implant. Okay, so you have your socket that tends to be a polyethylene lining, so a plastic, and then you have your head, which tends to be a metal. The plastic liner in the socket tends to have a small amount of cement in. Some situations it's metal back, sometimes it has special material to allow bone to grow into it. The humerus, so the shoulder component over on the side, tends to be an uncemented prosthesis. So it tends to be coated with a special material that allows bone to grow into it. So at the start, it's press fit. So we get a good fixation within your humerus by getting the correct size, putting it in, but then it's cleverly coated in a material that allows bone to grow into it. So in turn, giving you a rock solid implant that hopefully lasts you a lifetime. But again, this anatomical replacement requires that functioning cuff. So in some situations, I will tell my patients that when you're going down the shoulder replacement route, we will make a decision intraoperatively whether we're going to do an anatomical or a reverse shoulder replacement. And this is fully dependent upon your cuff muscles. Some situations you've had imaging before in the form of an ultrasound or MRI scan, which can paint the picture of how your cuff muscles are, but we really won't know until we go into your shoulder and have a look at the cuff muscles to make the decision whether they're of good enough quality that we can do an anatomical replacement. If the cuff is torn, damaged, or poor quality, then we're unable to do an anatomical. Now, all the times that we do a shoulder replacement, we will have both options available there at the time that we can execute either one of the prosthesis, and is the correct implant for the correct patient is the key factor there. So when it comes to the reverse was invented by the French a long time ago, and so a lot of us go into France to do our fellowship. So I spent some time in France with one of the inventors of one of the reverse shoulder replacements to learn how they did it and to bring the skill set back to the UK. The reverse shoulder replacement is a very clever way of changing the shape and the mechanics of the shoulder. So normally you'd require the muscles around that cuff muscles to hold that ball in the socket. But when they're torn and they're not there, you have to use a prosthesis to try and get that stability, to keep that ball within the socket. So the French cleverly invented swapping the socket for a ball and the ball for a socket. So reversing it around. So that's why we call it a reverse shoulder replacement. Now, I've had some patients that look at it and say, oh, is this experimental? Is this a new thing? No, this has been around for quite a long time. It was invented by the French. It's a very clever way of changing the mechanics of the shoulder. And so what this does is it changes the main driving force of the shoulder is the deltoid. This is the big muscle on top of the shoulder. So rather than being a backseat driver, it then becomes the main driver of the shoulder. And in turn, it also leads to a stability. So pushing of the humeral component against the ball from the socket and gives you that stable shoulder. So it gets new muscles moving that shoulder, that deltoid. So it's no longer a backseat driver, it's the main driver of your shoulder function. And so that's why it's important afterwards for you to do your exercises, because you'll need to beef up your shoulder muscles, the deltoid in particular, to get the best function you can for this. And it doesn't rely on the cuff. Now, in some situations, I may find that some of your cuff is damaged, some of your cuff is intact. And so there is a trail of thought that by reattaching certain cuff muscles on around the shoulder, you can get a better strength and a better function to your movement. So if and when you have your shoulder replacement and we've reattached certain cuff muscles, the reason we do this is to get certain better pulls of certain muscles to get you better strength and better function, if we can. Okay, if we go in and all those cuff muscles are torn off and they're very poor quality, then we don't tend to reattach them back on. So the operation, it is a large joint replacement, so it is a big operation to go through. It's a day case procedure. Now, the nice thing about the shoulder replacement is you can have a block at the time of surgery. So this is an injection within the neck done by our anaesthetist, and this numbs your shoulder. This tends to give you a numbing for about 16 hours after the surgery. So most patients leave hospital smiling, and they need to make sure that they've got painkillers on board before that block wears off. It is a large joint replacement, and you should have correct painkillers on board, so you're not in pain. You should be comfortable, and you should be supported with your painkillers. Majority of our shoulder replacements at Eastbourne and Conquest are done as day case procedures, but if you require an overnight stay, some patients stay in overnight. It takes about an hour to an hour and a half to perform the surgery, and we plan this surgery before. There's ways that we can improve the accuracy of your shoulder replacement. So this is the thing that you don't see when you come and see us in clinic. This is the thing that we plan and prepare for behind the scenes. A lot of the time you'll hear us getting a CT scan for your shoulder after you've seen us in clinic, after you've made the decision to go down the shoulder route. I'll request a CT scan. So you're never going to see the CT scan. You can if you want to, but the whole point of this CT scan is to put it into a computer software to allow us to plan it. So one of the modern advances of shoulder replacement surgery is the ability for you to plan the surgery on computer. So this is very important for me because no patient is the same. The amount of wear that patients have of their shoulder is different every time. So it's important to understand what you're facing when you're doing a shoulder replacement, because you shouldn't be putting the same shoulder replacement in for every patient. You should be tailoring the shoulder replacement to the patient and the pathology they have. And the reason we do that is to try and maximize the survivorship, so to get your joint to last you a lifetime and as long as we can get it to last, but also to get you the best range of movement. Because your implant positioning, particularly with shoulder, will give you your outcome and your function. So it's very important that we position it in the best position that we can. Now, if you've got small amounts of wear, then you're going to have less of a deformity, and you can use certain prostheses that we have on the shelf. Now, if you have a lot of wear that we pick up in our 3D templating, in our imaging preoperatively before you have your operation, you may need special custom implants ordered in, try and give you that best positioning of your implant and to give you that best range of movement. So this is why we do the 3D planning. In some situations, patients have worn their shoulder away so much that the deformity is quite great. So these are quite abnormal looking shoulders. So it's important that you identify these before the day of surgery, which is why we do this imaging before, which is why we pre-op template and plan it. And we can get special jigs in, special instrumentation that allows us to look at your current deformity that are tailored to you and allow us to do this, the proper implant in the correct position to get you the best position for that you can. I skipped there. The future of shoulder replacement that's coming is a development further building on of that 3D templating. So the 3D templating has been out for a couple of years. It's a fantastic way of understanding patients' disease, the deformity they have, and to give you that best implant. So the 3D templating is being developed to give us more accurate, more ability to manipulate the images that we have in there. It's a very fun way of a surgeon to plan your surgery. There's something else coming with certain implant companies called augmentation. So this is where you have ocular devices like glasses that can present certain 3D images or certain guides onto your visual field to try and give you an increased accuracy when doing your shoulder replacement. So this will be coming in the next few years, which is very interesting. So that will hopefully increase that accuracy and hopefully improve the positioning further of patients, give you that best range of movement. And ultimately down the line, there's the option of doing robot replacement surgery as well. This isn't me being replaced by a robot. This is me using robotic software to try and improve certain positioning of certain implants as we're doing it, particularly that socket, because that's the challenging part of shoulder replacement. This is why we do our planning, and this is why we get your imaging before. The shoulder replacements are big surgery, but it is a predictable, good operation to undergo. So a lot of my patients, I tell them it's going to take 3 months to recover from this. I usually tell them there's going to be a period of time of a sling immobilization. This is usually in the region of about 4 weeks. So I tell the patient that the wound, which is going to be as small as it can be to put in these implants, is over the front of the shoulder, and it takes about 2 weeks to heal. So you'll see me in clinic at 2 weeks to make sure this wound is healed, to make sure you're not having any complications, to answer your question, and to make sure that you've got the correct physio and rehab plan in place. Because there's certain points as you're recovering that will be supporting you to get that best function and to protect that shoulder. So you'll leave hospital with the block, with a numb shoulder, with a painkiller pack as well that will support you with your painkillers to try and make you as comfortable as you can. You shouldn't be in severe pain. You shouldn't be in much pain. You should be comfortable with the analgesia that we give you. And we give you a collection, and it can be increased if you find there's any breakthrough pain. The wound takes 2 weeks to heal, and the physiotherapy starts immediately. So the physio is going to work on different aspects. Although we've done the shoulder replacement, it's paramount that they move your elbow, hand, and wrist as well. So we don't want these joints getting stiff, because if anyone goes in a sling for 4 weeks, their elbow is going to get stiff, their hand and wrist is going to get stiff and swollen. So it's paramount that you move those joints regularly. I tell patients 4 times a day for 20 minutes. Try and decrease the stiffness. Depending upon whether we've reattached your cuff or not, you may have a limitation to your movement to allow it to heal, or we may get you going straight away. There will be specific advice to your physiotherapy and your team tailored to you and to get the best outcome we can. Most patients return after the 6-week period when they're able to get their arm to the top of the steering wheel and control a motor vehicle and go back driving. The physiotherapy starts immediately, and they will give you a list of exercises, arrange it either face-to-face or virtual, and will gradually increase the activities that you do. So that's shoulder replacement. That's a whistle-stop tour of shoulder replacement. So now I'll move on to cuff tears and hopefully answer a couple of questions of that. And then at the end, we'll go through any questions that have been posed for us. The cuff tears, so this is a lovely image that shows the muscles around the shoulder. So these are the muscles that hold that ball in the socket. The shoulder has the most movement of any joint in the body, and it's reliant upon a small bony surface, but a big cuff muscles that allow that shoulder to be moved around. So these cuff muscles are vital, and if one of them have a significant tear, this can impact upon your movement and can impact upon your pain and function. So a tear of the cuff, it can be partial, it can be a full thickness tear. So you can have small tears that goes through the cuff, and you can have tears that go all the way to the cuff. You can have tears that are torn to such degree that the tendon's ripped off and retracted back. So there is a big spectrum. There's also the degenerative tears that can develop with aging as well. Okay, so just because you have a tear doesn't mean that it's an acute tear. It may be a chronic one. And in those type of situations, we tend to examine you, take a full history, and get more detailed imaging. So the imaging that we have for looking at cuff tears tends to be an X-ray, to look for any arthritis, to look for the centered head, and then an ultrasound, because an ultrasound is a very accurate way of looking at the cuff, but it doesn't give us a good indication of the muscles actually in the shoulder. So the MRI tends to give us a better indication for that. So the MRI may give us an indication whether this is torn from a long time ago or whether it's torn recently, and where the quality of the muscle behind the tendon as well. So when these patients come in, we're looking to see which tendons are torn, whether there's an associated inflammation as well. Because a lot of the time when you have enough trauma to tear a tendon, there's going to be inflammation, swelling around the shoulder as well. So we'll be examining you, taking a history, to see what else could be driving your pain in your shoulder. So a lot of these cuff tears present with pain. Sometimes there's a history of trauma. That trauma can be big, falling from a bike, falling from standing height. Sometimes it can be small. It can be reaching for items on the background of a degenerative tear. So it doesn't have to be a big trauma that can propagate it. Sometimes these patients find that their pain and range of movement just gets progressively worse over years with certain events that lead to it. And these events may be a tear that developed in one tendon and subsequently another injury of a tear that developed in another one. But what my patients commonly report is a pain. It's the pain when trying to use those tendons, using those muscles, lifting up items. They also report a fatiguing, so a tiring when doing certain activities. And in turn with that pain and that weakness comes the poor function and the poor movement. They say they can't get their arm up in certain positions. They're struggling with activities. If they're working or if they have hobbies or activities at shoulder height or above, they can't do it with this arm. They're struggling. Now, a lot of the time when patients have cuff tears and poor range of movement in their shoulder, they will have what we call compensatory mechanisms. So this is basically where I tell patients, cheat. So basically, you're trying to bring up your shoulder into a position to allow you to manipulate or use an object above shoulder height. And what my patients commonly do is they tilt. They raise up their scapula to try and make it look like they're getting a bigger range of movement. When in fact, if you bring it down, isolate the shoulder, you'll see that their grossly limited range of movement is actually quite significantly impacting. And similar to that arthritis I mentioned before, when my patients have cuff tears and they've had them for quite a while, they will stop doing activity. They'll stop using that arm and they'll find the reason they stop using it, they know it will hurt, they know they can't do it, and they really struggle to do those activities. Now, some of the manual workers I treat who work above shoulder height, your plasters, your decorators, or certain manual workers, really do struggle getting that arm up, and they find that they can't even hold their arm up in the position to do their day-to-day activities. So if this is you, you've got the history of trauma, if you have any reported aspect of a cuff tear, you've got any imaging, then you can come to see us. The imaging, as I said, we'd get an X-ray, we'd get an ultrasound or MRI scan, depending upon where you are in the journey of your cuff tear. When it comes to the treatment of the cuff tears, again, surgery is usually a last resort for this. We explore similar to shoulder arthritis, injections and physiotherapy. The reason that is that injection can help settle down the pain and inflammation within the shoulder, because not only are you going to have that tear where your tendons ripped off the shoulder, but you're going to have an associated inflammation and swelling to the tendon and the tissues as well. So with the injection, we couple that with physiotherapy. The whole point of the physiotherapy is to see whether we can compensate for your tear. So the compensation is you beefing up other muscles, in particular that deltoid, that outside muscle, to see whether we can beef up to such a degree that you can compensate for the activities and movement of daily living and avoid surgery. Because in some situations, when you have a cuff tear, an injection and physiotherapy is able to get you back to that functional level. Now, if you're a heavy manual, if you do sports or activities, or you have a very large tear, you may find that your pain and loss of movement, even after physio and injection, is so that you can't do the activities of daily living, that ache and pain at night keeps you up and significantly impacts upon your function. So these are the patients we'll discuss going down the surgery route. And it's key that you've explored the non-operative first, but it's also important to get the right diagnosis. So when patients come in with the pain, with the weakness and decreased range of movement, we will take a full history, learn about the journey you've had with your shoulder pain, and then do the appropriate imaging in the form of the X-ray, ultrasound, or MRI scan. If you do go down the surgical route, and obviously this is the lecture by itself, so I'm going to talk about surgery more than non-operative options, but it tends to be keyhole. So keyhole is small, 0.5 centimeter stab incisions around the shoulder and allows us to pass in a camera and instrumentation into the shoulder to allow us to have a look around. So when we do a shoulder arthroscopy, we do a diagnostic first. So we look inside your shoulder, outside your shoulder joint, to make sure that we know what's going on. We take lots of pictures so we can show you after. We do a diagnostic. So we make sure we know what's driving your pain. We look through all aspects of the anatomy around your shoulder, and we'll confirm that cup there if we're expecting it. Usually we have the idea of what we're expecting from the imaging of the ultrasound, MRI and clinical examination, and then while we're looking inside, we're able to confirm that. Once we've confirmed that, we have everything available to reattach it back on. The reattachment tends to be arthroscopic again, so it's through the same small stab incision portals. So gone are the days of the big saber cut. Now it's small keyhole surgical portals around the shoulder. We use arthroscopic instrumentation to mobilize, to move your cuff back to where it should go back. And then we put small anchors deep into the bone with suture material that get those tendons to heal back down in the correct position. It's a day case surgery. Again, patients have a general anesthetic and a block. The block is the injection within the neck done by the anesthetic team. It's not painful to have done. It takes a few minutes to do, and it's a fantastic way of leaving your arm numb for the surgery, but more importantly for you to recover after the surgery. So this block will allow you to leave hospital comfortable and hopefully pain-free. It will give you time to get painkillers on board to allow your pain to be controlled. And I do tell my patients it's important that you take your painkillers before that block wears off, because it's important to have some doses of painkillers in your system for them to be at the correct dose within your blood to allow you to have that pain relief. If you're waiting till you've got pain before you're taking it, then you may have to wait a number of hours before you actually get the pain relief from that painkillers. So it's important that you take painkillers before that block wears off. You're going to have a sling for a period of time. So if we reattach this tendon back onto the shoulder, then you need to protect the tendon repair for a period of time. If you've got great tissue, it tends to be about 4 weeks. If you've got on the poorer side of tissue, it can be 6 weeks of protective movement. So you wear a sling for that period of time. We're going to give you a movement arc to allow you to wash your arm, move your arm gently in certain movements, but it's mainly to protect the cuff repair that we've done, that we've reattached back on. You'll have physiotherapy that will also go through those hand and wrist exercises and what you can and can't do with your shoulder whilst it heals. And they'll give you a list of exercises and they'll arrange follow-up as well. You tend to see me in clinic at the 2-week mark. This checks that those portals have healed. Also gives me the opportunity to go through the surgery with you. So I'll show the pictures, and in some situations, if you ask, we can give you a copy of the video of the shoulder arthroscopy, which will go through the different aspects of what we've done intraoperatively, and I'm able to explain to it. A lot of the time after the surgery, when I discuss with patients what we've done, a lot of patients don't remember that element of our consultation after the surgery because of the anxiety, because of the stress of surgery, but also because the anaesthetic's on board. So some patients don't recall that chat. The 2-week follow-up is to make sure there's no complications, make sure you're doing well, and also to go through the operation and your rehab plan to get your function back in there. So that's for the 2 weeks. So following up, you're going to have your sling for a period of time. Your wound will take 2 weeks to heal, and you'll see us in clinic at the 2-week mark. You'll have physiotherapy immediately to go through those hand and wrist and elbow exercises and to give you that range of movement arc that you can do with your shoulder to protect that cuff repair and to allow that shoulder to heal. Similar to shoulder replacement, most patients will return to driving the 6-week mark when they're able to get that shoulder up. Point of view, when you're at the 6-week period, physiotherapy will increase the intensity of the activities they do with you. So they'll look at 2 main aspects of your physiotherapy. This will be your range of movement, because your shoulder's going to be stiff because your cuff muscle has been reattached back on, looking at stretching exercises for your shoulder to get that movement back, and then ultimately the aim of it all is to get that function back. They'll look at strengthening exercises to look at certain muscles around the shoulder to beef them up. Now, some of these muscles and tendons may have been ripped off a number of months or years ago, and in turn, these tendons need to be beefed up and brought back up to strength. So a lot of the time, patients can report an ache after the surgery. This ache can be a weakened muscle that you ripped off previously that we've reattached back on, and it's not until you beef these muscles up where that pain settles. So I tell a lot of my patients afterwards, when we see them in clinic, that's important that you look at different aspects of pain management after the surgery so you can have your pain supported. Because as I said before, with joint replacements, it's important that you're not in pain. It's important that you're taking the correct painkillers so you're comfortable. So I tell my patients to get one of the bean bags they put in the microwave to allow it to go on the shoulder to help with pain relief. A lot of my patients use a wet tea towel, bag of peas or ice to help with any swelling they may have in the shoulder. Some patients try topical gels in the form of Voltarols and other analgesia to apply directly to the skin. And then some patients take regular painkillers as well. The regular painkillers as well is a ladder. You start off with your simple painkillers, your paracetamols and ibuprofen, then it increases up with your weaker morphines, your codeines, your tramadols. And if stronger painkillers are required, we can work with your GP to make sure you're supported with that. But again, the painkiller pack the patients get when they leave hospital should leave you comfortable, and you shouldn't be in too much pain after this surgery. But I do tell patients to maximize the results they get from physiotherapy is to make sure they have painkillers on board, to make sure they have hot cold therapy to support the shoulder. They can beef up those muscles, get the strength back in the shoulder, and hopefully get the function back. So that's a whistle-stop tour of cuffs and arthritis. I think we're going to cover some questions now that may have been posed.
Hello, I'm back. Thank you very much. That was really helpful, Matthew, and incredibly insightful. And I'm sure everyone found that very helpful as well. Now, we'd like to open the floor to some questions. We've got about 10 on the side there, but if you have any questions to ask, then you can pop them in now and they will they'll arrive at the top of the page, so I will get to them. So I will start at the bottom here. We have one which says, hang on, what is the impact of taking years from initial injury to seeking diagnosis and help?
Is that cuff repairs, did it mention, or for arthritis? It doesn't say.
It doesn't say.
That's fine. No, that's fine. So we'll first probably focus down, we'll answer both. So from a cuff tear point of view, that's a good question. So it depends on the age of patient, and it depends on the quality of the tissues that you have, okay, and the functional demand that you're expecting to get back doing. So if you're an elderly patient with low functional demand, then a cuff tear may not have as big impact upon you as if you're a active patient, a little bit younger, with hobbies or activities or occupations that need the shoulder function. So when it comes to these injuries, it is important to get the right diagnosis and to go down the right treatment plan. Because with all of these treatment, the aim is to get your function back. So the earlier that we can see you is what I'd say would be the better option. And the reason that is it allows us to tailor the treatment for you. Because although we're surgeons, the last resort is surgery, and conservative measures of the injections and physio will be the first port of call. So I think the answer to that will be if you're having pain, poor movement, or function, irrespective of your age, an earlier referral is more helpful because it allows us to instigate the treatment, get you back to a functional level. Now, if you don't respond to that injection and physio and you're appropriate for surgery, then you'll be going down the surgical route. But I think the key thing is the point of this, we're not saving your life, but we're definitely improving your life and improving your function. And so if you are struggling, then go down the path.
Okay, thank you. Right. How much can be accomplished by treating shoulder injury through physiotherapy and exercise? And what are the signs that more serious intervention is required?
A great point. So it all depends upon the diagnosis and the pathology you're having. There's a huge spectrum of shoulder pathology that you can have with different levels of severity, ranging from your small degree of inflammation to a tendon, to your torn tendon, that cuff, arthropathy, or advanced arthritis. There's a big spectrum of things that you can do. Now, physiotherapy and exercise is absolutely vital to every stage of shoulder surgery and shoulder intervention, because it's the joint that has the most range of movement in the body and it's most dependent upon the muscles around it. So it's paramount that you maintain these muscle bulks. But it's also important with your shoulder pain that you have the correct diagnosis, that we know what's going on and that you're getting the correct treatment for it.
Okay, thank you. This is a little bit similar, actually. How do you know when you need surgery for severe arthritis in the shoulder?
Yeah, it's a good point. So I think it's a great point. So one thing I teach my juniors is that just because you have arthritis on an X-ray doesn't mean that the patient's going to be significantly symptomatic from it. So your X-ray picture is only an X-ray picture and it isn't the clinical picture you're getting with the patient. This is why we take your history. This is why we examine you and see the functional impairment and find out how much is impacting upon you to correlate that with the x-ray, because sometimes patients will have mild arthritis on x-ray but have very severe symptoms, and sometimes patients have moderate arthritis on x-ray and have only mild symptoms. So it does vary from patient to patient. The severe type tends to have very severe symptoms, but there is a spectrum. When it comes to the triggering factors for surgery, I'd say most of my patients say pain. It's a night pain. It's an ache. It's an ache that won't go away. It's the pain that spreads up to the jaw, down to the arm, and it's constantly after activities, and you're always aware of it. And then secondly, I'd say it's the poor function. So it's the rotation. It's that they know their shoulder won't move to those positions. And again, that may be due to the soft tissues, like the cup tears associated with it, but it may be due to that extra bone. So that extra bone may be hinging. And when you're getting to the point where that extra bone hinges, this will also produce pain and swelling within your shoulder. So I'd say night pain and day pain, and I'd say poor function and poor movement is probably the main triggering factors. Because if you have a shoulder x-ray that shows a bit of arthritis, but you're fully functional, pain-free, there's no one who'd give you a shoulder replacement for that. We would leave you well alone. But if you're someone with moderate arthritis of the shoulder and you're crippled with pain and you're really struggling with night pain and you've exhausted physio and injection, then this is the operation for you.
Okay. Are there better alternatives to surgery? I presumably what we're looking at there is can exercise help?
Alternatives. So this is why we always do the conservative route first. This is why most patients who have come to us have already had physiotherapy, have already done range of movement and exercises, already go to the gym or do those type of activities, tried injections. And so the point they actually come to us is usually not the start of their journey. It's usually halfway or down to the end of it. So a lot of the time patients will do that. Now, with relation to other treatments, so if you're looking at alternative therapies, then there isn't any strong evidence to say that that can stop arthritis progressing or be an alternative to shoulder replacement. I think the big factor I would like to highlight is that surgery is a last resort, that conservative measures are first in the form of injection and physio. However, a shoulder replacement is a predictable way of getting you back close to pain-free function beyond 90 degrees is what a shoulder replacement will restore. And that's what we're looking at, is to get your function back pain-free. And so that's what the whole aim of a shoulder replacement is to get you sleeping, to get you using it and functioning with your shoulder again.
Right, thank you. What is the recovery time and restrictions on the use of the shoulder after surgery? I was thinking about this because you've got quite a few people who go to the gym and take exercise. So how long do they need to take off before they can return to that sort of lifestyle?
Yeah, so with both of these procedures, you may be limited for a period of time, as I said, in a sling to allow the tissues to heal back down, to allow you to recover. After that, you're going to have a controlled rehab. Now, the gym is a fantastic thing in a controlled sense. So we'll be giving you a list of exercises from your physiotherapist. You're going to work on the range of movement and strengthening. So if you're doing them at a gym or home, it doesn't matter too much. But with the gym-wise, when you progress up, because we give you a series of bands first, when you progress up, you can then go to light weights with high reps to try and rebuild the muscles around the shoulder. So gym work can work brilliantly for rehabbing a shoulder, but it has to be controlled. And it has to be at the correct point within your rehab, because you can't do it too soon. Otherwise, you can damage your shoulder. And it's important that working with your physiotherapist, they can encourage you when to go back to the gym, and you can check with them what activities to do in the gym to allow you to get the maximum out of it. A lot of my patients ask about swimming, and swimming is a great activity to help go back and rehab the shoulder. And I encourage most patients to go back in around about the 6-week mark or after. Your wound would have been fully healed by then. You'll be working on physiotherapy to get your range of movement. You won't be doing butterfly from day one, but you can hopefully build up your activities of the shoulder down the line.
I've never been able to do butterfly, but anyway, how many injections can you have before progressing to surgery?
That's a great point. So the injections are there for a local anesthetic and a steroid. The whole point is to bring down some inflammation within the shoulder. Okay, so if you've got a tendinopathy, if you've got an inflamed portion of your arthritis that's really aggravated your symptoms and it helps and brings it down, fantastic. But what you find with a lot of patients is that the arthritis still has the limited movement, that they have a diminished return to the injections. They have one injection, they may get a couple of months, they'll have another one, it's then weeks, and then they may find that another one down the line has little to no response. Now, the big factor with this is we are limited to the number of times we do it. And the reason that is it contains a steroid. The steroid can cause bone problems, reabsorption of the bone around the injection site, and it has a risk of infection as well. So I wouldn't do injections regularly. We tend to leave a period of time between them. Classically, we talk about 3, but the point of the injections is to see whether we can settle your pain and get you back to a functional level. If they're not working for a reason, and that may be the time that you then progress onto it. So the big thing I tell patients is not to blindly inject regularly, that you should be having targeted injections, and you should have someone keeping an eye on your symptoms to make sure whether you are recovering and getting back to normal, or whether this is just repeating the same thing that doesn't work.
Okay, thank you. How can we increase successful outcomes for older patients?
So from a shoulder replacement point of view, so I think the key thing that I've highlighted with my practice is tailoring the implant to the patient. So the big thing is appreciating the deformity you have. So you will have wear and tear of your ball and socket joint. You will have different elements that are worn away. And it's important that we recognize this, that we put the implants in the correct and best position to get your best function from it. Because what we want to do is to get the best function, get the best longevity, so the implant will last you a lifetime, and to get you the best result. So from my point of view, it's appreciating your disease. It's getting the CT scans, getting the imaging, and ultimately down the line using augmented reality and potentially the robot to get that best implant positioning. From a patient point of view, so optimization of health prior to the surgery. When you go through the surgery, obviously having the correct support in place, and then after the surgery, having a painkiller pack, correct support in place, but also motivated to do the exercise. So it's very key that afterward, the patients that do well are the ones that are motivated, do the exercises and activities to get the best result. Because again, the shoulder has the most range of movement in the body because of the muscles around it. So it's vital that you beef up those muscles and do the exercises that the team go through with you after the surgery.
Right. And then we've got 2 more questions. One is, what is your selection criteria for day case shoulder arthroplasty? No. I can speak.
That's a great question. So I set up the day case shoulder arthroplasty pathway for Eastbourne and Conquest. And so there is the selection criteria for that. This is seen at pre-op. So we may identify the patient potentially for day case. These tend to be patients who have a support network at home where they can have leave hospital the same day, that they have a painkiller pack on board, but more so that they have certain medical conditions that can be dealt with at the time and don't need overnight monitoring or support. So we identify in clinic potential patients for day case. The patients then go through the preoperative assessment. They will have the questionnaires that are performed by our pre-op team to see whether you may potentially be for a day case surgery. We then have a day case pack to give to the patient to make sure you're comfortable, because again, that block there, so your shoulder should be numb and you should be comfortable. You're going to have painkillers on board. A couple of things we need after the surgery. We need you to see physio. We need you to have an x-ray as well. And if they all go well and you're comfortable and you're happy to go home, you will be a day case patient. If you feel that there's any reason you need to stay in overnight, or if there's any medical problems we need to keep an eye on, or if you have those medical problems before and you're identified as overnight stay, then you will have that overnight stay. You'll have that support network in place. Now, if you're identified to need a higher level of care as well, like we have over in Eastbourne and Conquest, then we can get certain beds, like high dependency beds, on standby for you. So it's important that we identify what medical problems you have, make sure you're the right patient for day case, but even if you're not, that you can have overnight stay and have the correct support in place so we get you through the journey safely.
Okay, and then the final one. So if anyone wants has anything else to ask Matthew, then if you could type it in now. But otherwise, it's, do all rotator cuff injuries need surgery?
No, they don't. So again, it depends on the level of tear. It depends on the location of tear. So there's main tendons around the shoulder that will do certain movements as well. It depends upon the age and functional demand of the patient. So I would say no, they don't all require surgery. Majority require the injection of physiotherapy first, and then surgery is there for the patients who don't respond to it. these cuff tears don't heal back down, and it all depends upon the functional demand that you're trying to go back doing. If you're a high demand, high functional patient, if you're working, if you have hobbies or activities that involve your shoulder and you're unable to get back to that functional level, the surgery is definitely one of the options for you.
Okay. And we have 2 more have come through. So how long do you expect to be in pain after surgery for a cuff repair?
So with the cuff repair, it is surgery that, although it's keyhole, so outside you'll have small stab incisions, it is a operation where we reattach a cuff onto the bone. So it can be uncomfortable if you don't have painkillers. So the painkiller pack from the surgery will take a number of weeks to support you. If you need painkillers beyond that, you can go to your GP to support you for longer. Now, what a lot of patients find is in the first few weeks, it can be uncomfortable if you don't take your painkillers, so you should take them. But the pain settles quite quickly. And then what happens is when you start mobilizing that cuff that you've ripped off or that we've reattached back on, you have a different type of pain. So the patients report a different type of pain. So the pain of surgery settles down after a week to 2 weeks, and you're supported with painkillers from that. And then when you get going with physio, there's a new pain, which is an ache of a weak muscle. So when you beef up that muscle enough, which is what I tell patients, usually around the 3-month mark after surgery, the pain should disappear. So when you beef up that muscle enough for you to do the movements of day-to-day living and activity that you want to go back and doing, then that pain should settle. But the night pain that patients get when they're doing their physio is the weakness of the muscle that we reattach back on. Because a lot of the times the muscle that's been ripped off gets weaker, gets swollen, gets sore. And so when we reattach it back on, you're using a muscle that you haven't used for months to years. And so that's why it's sore and that's why it's swollen. But again, you don't have to be in pain with these. We can support you with painkiller packs, and your GP can support you with painkillers as well.
Okay, and then the final one. If you have a cuff tear, are you making it worse with racket sports, or is the exercise a good idea?
So definitely exercise is a good idea, but the question is what the level you're getting back to. So again, when it comes to these cuff tears, what you're doing is you're compensating and beefing up the other muscles around the shoulder for your range of movement. So certain activities in sport may not rehab your shoulder as well as focus physio, swimming or other activities, but we do want you going back to this. So the whole point of the shoulder prosthesis and the shoulder operation for cuff tears is we're not saving your life, but we're trying to improve your quality of life and your function. So if you want to go back to those, then yes, physio, exercise and activities is a way to do that. But if you find you're unable to go back to those activities, then surgery may be your option for that. And patients who have shoulder replacements, cuff repairs or whatever, can go back to those activities. And they can go back to golf, they can go back to tennis and other activities as well.
Okay, that's lovely. Thank you very much. Those are all the questions. So once again, thank you, Mr. Ricks, for providing such an insightful presentation. I learned a lot from that, and I've got 2 phone calls to make to a couple of people after this. Everybody who came along this evening, thank you very much for your time. And don't forget that you will be receiving a copy of this video tomorrow. And if you have any further questions or you'd like to book a consultation, then please don't hesitate to contact us via the details that have been on your screen, or they will be in the email tomorrow. Okay. Good evening.